Bismillahirrahmanirrahim. Today, the topic of presentation is mesenchymal odontogenic tumors. Mesenchymal odontogenic tumors are those tumors which are derived from the mesenchymal portion of those tissue that later on participate in the development of the teeth, periodontal tissue, tooth pulp, dentine, root, cementum, periodontal ligament, and the parts of the bony socket that houses roots of the teeth. So the learning outcome for this lecture would be to describe the mesenchymal odontogenic tumors, discussing their clinical, radiological, and histological features, and then discussing their differential diagnosis and different treatment options. Odontogenic fibroma, odontogenic myxoma, and cementoblastoma, they come under the heading of the mesenchymal odontogenic tumor. We will discuss all three of them one by one. So let's start with the odontogenic fibroma. Odontogenic fibroma, these are the benign tumors which are derived from the connective tissue of odontogenic tissue. These may contain islands and some strands of the inactive appearing odontogenic epithelium and some calcification. There are two variants of odontogenic fibroma. One is the central that will arise within the bone, and peripheral which are located within extraosseous location, or peripheral odontogenic fibroma. They arise within the soft tissues of tooth-bearing areas. The peripheral odontogenic fibromas, they are common as compared to the central ones. These lesions are usually uncommon, and they may arise in a wide age range, starting from 4 years of age and goes up to the 8 years of age. Females are slightly more prone to be affected by this condition. These lesions usually present as an asymptomatic swelling, but if the lesion is ulcerated, it may become painful. Maxillary lesions are usually located anterior to the molars. However, in mandible, these lesions are located posterior to the molar teeth. This is a picture of the peripheral odontogenic fibroma. This is a solitary nodule, soft tissue nodule, arising within the tooth-bearing areas of the mandible. It is non-ulcerated. Its color is exactly the same as the surrounding mucosa. Radiographic picture of the odontogenic fibroma shows it is a well-circumscribed unilocular radiolucency, and its border are sclerotic. In some lesion, radiopaque flakes may be seen. As the lesion enlarges, multiloculations may be developed within the odontogenic fibroma. These lesions are usually associated with a root resorption of the associated teeth or root divergence. On histopathology, odontogenic fibroma may present as two types. One is a simple one, and other is the WHO type, which has been recently described. In simple odontogenic fibroma, as you can see in the upper right corner of this slide, you may find a photomicrograph. It shows fine collagen fibrils. Again, this fine collagen fibrils are lying the widely spaced, stellate, and delicate kind of fibroblast. This is called the simple kind of the odontogenic fibroma. However, if you see underneath this picture, you will find a hypercellular lesion with scattered islands of the odontogenic epithelium. This yellow arrow shows toward the strands of the odontogenic epithelium. These odontogenic epithelial islands, they are lying against the fibrous stroma. Important thing to note down is that these WHO type of the odontogenic fibroma, they are lying and they are quite closely associated with the central giant cell granuloma. So that is why I think they have put this WHO type in a separate category. This is again another photomicrograph of the odontogenic fibroma. Let me explain a bit. The black arrow points towards the stellate fibroblast. Red arrow points towards foci of odontogenic epithelial island, and the yellow star represents the background fine collagen fibrils. Differential diagnosis of the odontogenic fibroma includes ameloblasttic fibroma, odontogenic myxoma, desmoplastic fibroma, and in peripheral location, the DDs include irritation fibroma, peripheral giant cell granuloma, and pyogenic granuloma. The best treatment is to excise them if they are located in the peripheral location, and in case of the central lesions, enucleation and curettage is the best possible treatment. Recurrence is usually not associated with odontogenic fibroma. Odontogenic myxoma. Odontogenic myxoma, these are the aggressive intraosseous lesions which are derived from the odontogenic connective tissue. They consist of the spindled mesenchymal cells which are lying against the background of a mucoid substance. If you can appreciate in the lower right corner of this slide, you may find a picture of anterior teeth. Underneath these anterior teeth is lying a well circumscribed grayish white gelatinous kind of mass within the bone. These lesions, odontogenic myxomas, they are usually uncommon. They slowly enlarges and may not cause pain. However, with rapid growth, they may become aggressive and they may cause destruction to the surrounding structures. If the lesion occurs in the maxilla, they may invade the sinus. Mandibular lesion, they will extend up to the ramus. Odontogenic myxoma on radiography, they appear as unilocular or multilocular radiolucency with irregular and scalloped margin. If these lesions they appear multilocular, multiloculation may appear as soap bubble, honeycomb, or tennis racket kind of appearance. The soap bubble and honeycomb appearance is exactly like that of the ameloblastoma you may recall from my last lecture. This lesion may cause expansion of the cortical plates. They may displaces the adjacent root, but resorption of root is usually not seen with this lesion. In another radiographic picture, you may see a straight internal septa producing the tennis racket kind of appearance. It is said that if you find at least two straight septa within a suspected odontogenic myxoma radiographic picture, it is said that this is a diagnostic point. On histopathology, odontogenic myxoma, it appears as mucoid non-fibrillar substance. Within this mucoid substance lying the angular and spindled kind of cells. This mucoid substance is consists of the glycose aminoglycans, for example, chondroit and sulfate. This lesion at the periphery, it will penetrate the surrounding bone and trabeculae, and thus by resorbing some of these trabeculae, islands of the residual bone will be seen adjacent to these lesions. Differential diagnosis of the odontogenic myxoma, it has a long list on clinical and radiological. It can be confused with intraosseous hemangioma, cherubism, aneurysmal bone cyst, ameloblastoma, and so on. On histological basis, it can be confused with a rhabdomyosarcoma, myxoid liposarcoma, neurogenic sarcoma, neurofibroma, and so on. The best treatment for odontogenic myxoma is to curate them, followed by chemical cautery of the bony walls, but the best treatment is the block resection. It is very important to remove the whole tumor as an intact specimen. This is very important as to you should retrieve each and every bit of the tumor in order to reduce the chances of recurrence. Cementoblastoma. This is a benign, well circumscribed tumor of cementum-like tissue that grows in continuity with the apical layer of the teeth. It is said that this is the only true neoplasm of the cementum. This tumor is uncommon. It is usually seen in second and third decade of the life. More than half of the lesions are seen within the mandibular area, and especially within the mandible, molar and premolar areas are the specifically affected. This causes expansion of the buccal and lingual cortices. And more than half of the cases, they may present with pain and swelling. However, the interesting thing is that these lesions are associated with the vital teeth. The teeth, the teeth involved by this tumor would be vital. The radiographic picture of the cementoblastoma shows a well demarcated and unilocular radiopaque mass that has been fused to only, either a single or multiple roots. And if you see closely, you will find that this whole radiopaque mass is surrounded by a thin radiolucent rim, which represent the periodontal ligament. Root resorption and fusion of the tumor, these are the consistent features. Cementoblastoma on microscopy appears as conglomerate masses of the cementum. And within these masses of the cementum, you may appreciate the reversal lines. Cells are seen enclosed within the lacunae. This tumor in peripheral zone has an unmineralized tissue, while the central part of the tumor becomes more mineralized. Soft tissues lying within this tumor is loose, fibrous, vascularized, and they may be containing some multinucleated giant cells. Differential diagnosis of cementoblastoma includes osteoblastoma, osteoid osteoma, hypercementosis, odontoma, and focal sclerosing osteomyelitis. The best treatment for cementoblastoma is to surgically excise it. Because of the intimate relationship between root and the tumor, the tooth has to be sacrificed because it is not possible to remove the tumor and saving the tooth at the same time. Prognosis of this tumor is quite good, and usually the tumor doesn't recur. So this is the end of today's lecture. I would like to give you a small assignment. The question is, a mandibular mass that is radiolucent. It is characterized by strands of inactive epithelial islands with few calcification foci. And this whole epithelial islands and calcification foci, these are set against the background of the cellular fibrocollagenous stroma. I would like you to give me the exact diagnosis. What do you think it could be? And please list down the differential diagnosis of this lesion if you are not clear. And what do you think the best possible treatment for this lesion would be? That's all for today. Thank you so much. Allah Hafiz.